Good evening, everyone. I'm Dr. Sarah Mustafa from DentistChannel.Online. Welcome to today's webinar about diabetes from anesthesia to implant. While we are waiting for the participants to join the session, I will introduce you to our company. DentistChannel.Online is a digital dental media company. It is your marketing solution for dental events, product launches, workshops, and courses. We also provide a collection of scientific articles and blogs about different topics in dentistry. We work hard to be your first-hand information on the technological advancements in the dental field. Now it's time to start the session about diabetes from anesthesia to implant. If you have any question about this topic, please feel free to ask it in the question and answer box, and we will answer each and every question at the end of the session. I will start by introducing today's session speaker, Dr. Isra Goma. Dr. Isra graduated from the Faculty of Dentistry in Cairo in 2009. She got a MFD from Royal College of Surgeons in April 2015. After that, she got her master's degree in periodontology, oral medicine, diagnosis, and maxillofacial radiology from the Faculty of Dentistry in Cairo in 2021. She currently works as a course director at Master Key Academy, assistant lecturer at the Egyptian Russian University, and as oral medicine specialist at the Greenhouse Dental Clinic. Welcome, Dr. Isra Goma. It's our pleasure to have you with us.
Welcome, Dr. Sarah. Thank you for inviting me for joining this kind of webinars. It's a pleasure for me too.
It's our pleasure having you on our platform.
Thank you. I hope it will be an enjoyable lecture.
Hope so. You can start the session.
Thank you. Hello, everyone. I'm Dr. Isra Goma, as Sarah mentioned now. We are going to discuss diabetes or diabetic patient in your dental practice from anesthesia to implant. What we are going to talk about, first of all, I have to classify or to tell you our agenda in this webinar. First of all, we do not treat strangers. So we have to talk about our patient, our diabetic patient, in some details to know more about this condition, how to deal with. We are going to talk about the oral manifestations of diabetes. And we know they are a lot, complicating your work, complicating your dental work or any or your everyday practice. Dental implications. What do you mean about dental implications? How to manage a diabetic patient from anesthesia, extraction, any surgical work, till better quality of life as an implant. Let's discuss the first option or the first step in our agenda. Do not treat a stranger. I'm insisting in each webinar or any live or online lecture to discuss what is diabetes. We know about type 1 and type 2 diabetes. This is not a new information, but we have to understand how diabetes developed. It's a state of hyperglycemia. Glucose cannot enter the cell. That's why your body cannot get any benefits from glucose. So starting to use another substance, protein, fats, that's why your patient is losing weight. That's why this patient having a kind of a complication or multiple complications due to hyperglycemia, as a blurred vision, as an extreme tiredness, as an extreme fatigue. That's why your patient having glucose in his urine. That's why having polyuria and glucose in his urine causing a problem in his renal functions, cardiovascular system. And most of diabetic patient who is uncontrolled will end up with a cardiovascular complications. So we are not dealing with diabetes alone. Most of diabetic patient will have another kind of complication. And we are going to talk about the relation between complicated diabetes, not only a diabetic, your patient isn't just a number. So we have to know the possible complications you will see in your patient. As I said before, we shouldn't treat strangers. So how you are going to ask your patient? Most of us, or most of our dental practitioner in Egypt, just asking about what kind of diabetes you have, type 1 or 2, what kind of medication you are taking, to know it's insulin, injection, or an oral medications. First, you have to know the kind of medications your patient is taking. Not only it is oral or injection, no, you have to know the type, and I will discuss different types of anti-diabetic drugs that affect your choice of medications and affect your dental work. You have to know if your patient is taking his prescribed medications. It's very important. Sometimes your patient says, yes, my prescription is glenide or sulfonylureas, but actually he's not taking his prescription. So you have to know about this. You have to know the recent if your patient having any recent hypoglycemic crisis or hyperglycemic crisis. This is very important. The most recent laboratory finding of the fasting level, postprandial level, and A1C, not only a single investigation. You have to know the three of them. Does your patient have any other medical condition? As we discussed before, you know, the diabetes common with hypertension, you know, that diabetes common with cardiovascular condition, you know, that diabetes common with other renal function disease. So you have to know if your patient is diabetic and also have another medical condition. Do not be distracted with diabetes only. That's what I'm saying. As I said before, we do not treat numbers, but we have to discuss the numbers. The recent protocols or the recent guidelines for the controlled diabetes, according to the American Diabetes Association and the American College of Endocrinology, suggest that your controlled patient should be his fasting level less than 130 and his postprandial level less than 180. This is according to Scully 22, 2020. According to the American protocols and the Little and Flag as a reference, there is two numbers, two important numbers, less than 70 or higher than 20 milligram deciliter. What do you mean by that? This is the range we can treat patient with any elective treatment. As less than 70, please defer any elective treatment. This patient is very risky. And higher than 200 milligram deciliter, please defer any elective treatment. We treat only emergency in this range. But I just want to tell you something. The most important number is the fasting blood glucose, not the postprandial. Most of our dental practitioners just asking the patient when you did your last investigation and taking only the postprandial or something haphazardly done in any lab, and this is not adequate. According to the research, the fasting blood glucose level is the most important level that affect the reepithelialization and the wound healing after extraction or after any soft tissue manipulation. So the most important factor is the fasting blood glucose. If the patient is less than 70, do not work, or higher than 200. The other important numbers is A1C, glycosylated hemoglobin. This number, like an indicator, if your patient is controlled or not in the last 3 months. And actually, if I'm asking my patient about his A1C, and he's confused and telling me that he is not aware about this, I will be worried about his doctor, his physician. If I were you, I will think that this patient is not controlled anyway. A1C is a very important indicator for if your patient is controlled or not. And it's not a single number for all the patients. According to his age, A1C will change. According to his type of diabetes, type 1 or type 2, insulin dependent or non-insulin dependent, also your A1C could be changed. It is acceptable to have A1C 7% for adult patient. In younger patient, you can accept higher numbers. What does that mean? It means that you can accept a higher number from younger patient because it is difficult to control diabetes in younger population. So under 12 years old, we can accept up to 8 as a controlled diabetes. Above 13 years old, maybe 7.5% we can accept. So it's not a fixed number. It can change the controlled number according to age and according to type of diabetes. You have to know if the patient having any cardiac, having any renal, having any autoimmune disease before deciding, is this patient controlled or not? As I said before, you may have a good number or you may have a controlled numbers, but your patient having something else that increase the morbidity and the complexity of your situation. So it's not about numbers. Let's discuss some of the oral manifestations we can see in our diabetic patient. Of course, we know about the relation between diabetic patient and the periodontal disease. Most of them having an active, severe, aggressive periodontitis due to the affection of the immunity or the destruction of the periodontium of the inflammatory mediators that cannot be controlled during diabetic or hyperglycemia, during hyperglycemic period. If your patient is immunocompromised, you can see multiple, as we can see multiple fungal infections, candidal infections. We can see deep fungal infections, as we can see in the COVID-19 era, deeply seated fungal infection. There is an adequate relation between diabetes and lichenoid reaction. As we can see in this picture, there is an adequate relation between antidiabetic medication and lichenoid. And also an adequate association between diabetes itself and lichen planus. So it's very common to see lichen planus as a mucocutaneous disease affecting diabetic patient. With diabetes, patient complain from dry mouth. And with dry mouth, we have multiple complications. Starting from functional, the patient have difficulty to talk, starting from cervical caries, multiple fungal infections and bacterial infections. A patient can have difficulty in eating, swallowing. The hallmark for periodontal, or the hallmark for periodontal affection in diabetic patient is periodontal abscess. Periodontal abscess is not a common condition you can see in every dental practice. You can see periapical abscess, gingival abscess, periodontal abscess, not that common. But you can see it commonly with uncontrolled diabetic patient, as we can see in this picture. Periodontal abscess, very common with undiagnosed diabetes. Let's go for how to deal with this patient in our practice. We hear about numbers, we hear about oral manifestations, but we still need to know when to treat this patient. What's the best timing? Who can treat this patient? And which kind of patient I will treat in my clinic? And which kind of patient I will refer? Type of treatment I can offer for this patient, and type of treatment that could complicate my work. Where? This is a very important question. Not every diabetic patient can be treated in dental practice or in a general dental practice. Any modifications of the treatment will be discussed. So let's start. When to treat your patient? We know that we should treat our diabetic patient in the morning. Cortisol level will be adequate. And to treat diabetic patient first, to be the first client. Do not let your diabetic patient to wait in the diabetic room, the waiting room, sorry. But there is another factors that will affect your choice. Is your patient taking anti-diabetic medication or insulin? This will affect the timing of treatment. Anti-diabetic medications, I will discuss it in different ways. We just know that it is oral and there is injection. and I want to discuss it in different way. The common categories are sulfonylureas, glenides. They are the most common category used in treating or anti-diabetic as an anti-diabetic medication. If your patient is taking oral hypoglycemic or anti-diabetic, because there is a difference between anti-diabetic and hypoglycemic, not all anti-diabetic medication cause a state of hypoglycemia. And this is important because you are expecting a hypoglycemic coma in your clinic at any time if your patient is diabetic. So if your patient taking an oral medication, you have to make sure that your patient is having his first meal or breakfast and taking his medication. Some recommendations suggest that you can omit a single dose and recommend that your patient can take his dose after dental work. And why is that? You just want to keep your patient in a higher level of glucose to avoid hypoglycemic coma. But this is only a recommendation. It's not a protocol or a guidelines. So your patient is taking his oral medication and your patient is taking his breakfast. If your patient taking sulfonylureas, for example, the most common drug, Amarel, you have to avoid antifungal treatment as ketoconazole. It may increase the state of hypoglycemia in this patient. So be aware of. Use it local and decrease the systemic use of any antifungal. With the sulfonylureas, you have to avoid corticosteroids, and actually with diabetic patients, you have to be very cautious when you are going to use corticosteroids. If your patient is using the category of glenides, like miglinotide, it's a very common drug, you have to be aware of using the NSAIDs, non-selective anti-inflammatory drugs, because sometimes it's increase the metabolism with glenides and may increase the state of hypoglycemia in this patient. It's not forbidden, you can use it, but with limitation, not more than 3 days in most of cases. You have to be aware of using NSAIDs with glenides. If your patient is taking insulin, what is the best timing you can treat your patient? After the insulin peak. Actually, there are different and many types of insulin. Each type have a different insulin peak. Most of them 2 to 3 hours. In this 2 hours, your patient is in a state of hypoglycemia. So you have to avoid dental work in this 2 to 3 hours to avoid any hypoglycemic complication or crisis in your clinic. As we said before, we discuss when, who you treat in your clinic. You should first have your fasting level. To sum it up, first, fasting level to treat this patient. If it is adequate, okay. If it is not, you have to ask yourself, is it an emergency situation or something that can be delayed? If it is an emergency, do not dismiss your diabetic patient with infection. Even he is uncontrolled, you have to check his A1C. If his A1C also uncontrolled, this patient could be in danger. This patient could be in a sepsis situation or a septicemia. This patient could be vulnerable for destructive infection. So should I treat patient uncontrolled in my clinic? No, but you shouldn't send this patient home. You may refer for a hospital, you may refer for another specialist as an maxillofacial specialist, but delaying emergency treatment with an infection for a diabetic patient because he is not controlled is very dangerous. Before discussing to treat this patient or defer his treatment or refer for another doctor, you have to assess what you are going to do. Is it a single loose extraction for a loose tooth or a difficult surgery? The tooth condition itself, is it a long-standing remaining root with bone resorption around it or a difficult situation? So you have to assess the complexity before deciding to delay the treatment or an emergency treatment or to refer for another specialist? Where? This is also a very important question. Not all the diabetic patient can be treated in a general dental clinic. Sometimes we need in hospital. Why? In hospital, this patient, his insulin doses could be controlled. Even your patient, if he's taking anti-diabetic or oral medications, during this period in hospital, they can give him insulin and fluids, antibiotic, culture test, and this is not available in your dental practice. So again, does not mean if your patient is uncontrolled that he cannot be treated now. Prescribing antibiotics sometimes will not be the only solution. Sometimes it will be a dangerous solution, and I will show you some real cases about delaying treatment with a severe infection in diabetic patient. This was a situation we faced in our clinics, that a patient came with 70 years old with badly decayed loose upper right 7, with cellulitis in his right side. A patient wasn't okay, and the doctor was not that experienced. He think that the best action is to remove the cause and give antibiotic for the patient for 1 week or 7 days or 10 days. Unfortunately, we lost the patient after 2 days of extraction with cavernous sinus thrombosis. In this situation, this patient is old age, diabetic, can show up with sepsis. But unfortunately, the dentist cannot spot that he's having sepsis. That's why he think about that, okay, I will remove the cause now, I will prescribe antibiotic, and this is enough. And it wasn't enough. 10% of dental infections in the maxilla can develop or can reach the cavernous sinus and cause a very rare and dangerous complication as cavernous sinus thrombosis. Another example for dealing with different types of diabetic patient, 50 years old male type 2 diabetes, treated with metformin for 7 years. His body mass index was 42, then with diabetes or anti-diabetic medication, he's turning to 30. So he's well controlled. Remaining roots in long-standing upper left 6. The patient is well controlled. The patient is taking monotherapy for years. So this condition is a typical controlled condition that's suggesting you don't need to refer. You do not need to ask the patient to delay the treatment, just extract, but carefully assess the complexity, because it's very common with a long-standing upper 6 that you can cause an oroantral communication. And that's what happens in this patient also, an oroantral communication because of the bone loss, and it's very common with diabetic patients. But this patient is well controlled, even though it's not the numbers, it's not the condition of the patient now, it is the problem in the complexity. So you have to assess the complexity of the work. Third situation, a 39 diabetic patient type 1 since the age of 5. So it's a very long duration. This patient show up with a partially impacted lower wisdom with his first episode of pericoronitis. A patient is taking insulin and taking beta blocker with difficulty in swallowing. So this is a kind of deep facial space infection. Even your patient is young, even your patient is not having any other medical condition than diabetes, but this kind of diabetes is brittle diabetes, as the patient having different and higher doses of insulin and keep changing his insulin protocols. So this is a hospital-based. This is not a dental practice-based situation. This is a sad case for Dr. Hatem, as you asked him to publish this case. He's an oral pathologist. As we can see, this patient was a diabetic patient with an periapical abscess associated with the lower 5s. And the dentist mistakenly think that the patient numbers looks good. So we will prescribing an antibiotic, but actually the patient A1C wasn't that good, higher than 11, but the only patient, the doctor only asking for postprandial, and it wasn't that accurate. The patient, after prescribing antibiotic for 1 week, came back with swelling, pain, severe pain. They extract the 5, and unfortunately, there was a suppurative osteomyelitis that end up with removing half of its mandible. And this is a very, very sad complication because of not knowing your patient, because you treat a stranger. You do not read the full investigations. You do not ask for the full condition. You do not take a full history. Diabetes sometimes can be very simple case to deal with, and sometimes very complicated that need referral or not need hospital. To sum it up, while you are treating your diabetic patient, think of infection. Think of any emergency that can happen in your clinic. This patient may suffer of hypoglycemic coma in your clinic. That's why timing is very important, and do not prescribe medication that interact with his anti-diabetic medication also is very important. Think of other conditions that will complicate your case. Patient with diabetes can have hypertension or renal disease that will cause bleeding also. Think of medications that will increase the risk of having hypoglycemic coma in your clinic, as corticosteroid, as doxycycline, as ciprofloxacin, as NSAIDs, as we mentioned before. What kind of emergency you can face with this kind of patient? Of course, hypoglycemic coma. Hyperglycemic, it's not something common you can develop in a dental clinic, but this patient may be stressed, fear of dental treatment. Suddenly, you can see your patient maybe collapse, may having a seizure, may having a kind of confusion and stuttering, thirst and sweating. These are the common symptoms of hypoglycemic coma. If your patient is still conscious, give your patient 15 grams of carbohydrate. We call this the rule of 15. 15 grams of carbohydrate every 15 minutes. Measure his glucose. You have to own a glucosometer in your clinic. This is not an option. So if it is less than 70, give him another 15 grams of carbohydrate in 15 minutes. The most common example for this 15 grams of carbohydrate is half can of Coke. Very simple, rapid, and we can have it in your clinic. If your patient is having a hypoglycemic coma and already lost his consciousness, so you have nothing to do but giving him glucagon 1 milligram. It's a preloaded, and you can have it from in your clinic. It should be in your medical emergency kit, as any dental practice should have. Giving your patient better quality of life. Most of us, when dealing with medically compromised patient, they just stick to the rules. I will measure his glucose level. I will take I will think about any different consideration to treat this patient. I will delay his treatment if he is controlled. But we never think about giving your patient a better quality of life. Most of us afraid of giving patient implant, for example. Even though most of recent research suggests that success of implant in diabetic patient is higher than success of implant in a smoker, for example. And most of dentists will suggest implant for smokers, but will not suggest implant for diabetic patient. So let's discuss the recent evidence about implant and diabetes. Can we offer our diabetic patient an implant or not? Diabetes affect the periodontium or affect the success of implant in many ways. Insulin, of course, affected bone metabolism. Diabetes affected wound healing. And we know that there is a very intimate relation between the periodontium destruction and hyperglycemia. If you are going to offer implant for your patient, First of all, you have to start with a good patient selection, as any case in your work, in your dental work. Patient selection is very important. Any preoperative measures should be discussed with your patient, and you should know about it. We are going to discuss also the different surgical techniques that would affect the success rate of implant in diabetic patient according to the recent protocols. Also, the post-operative instructions and follow-up should be discussed with your patient. So let's start with the patient selection. Age. We know that there is no specific age for implant. We can do implants starting from 20 to 70. But if your patient is diabetic, you have to be aware about age and gender. Why? Because there is other situations that may complicate your implant, such your implant surgery or implant success. For example, female having higher risk of osteoporosis after certain age. So if you are going to offer implant for diabetic patient, female that is having osteoporosis, you have to be aware about the success. Onset. Early onset will have higher complications. Early onset suggests mainly type 1 diabetes. The duration itself. If you're having 10 years diabetes or 20 years diabetes, of course, 20 years of diabetes will have more complication if you are suggesting implant. You have to know if your patient controlled or not, and the procedure itself have to be as traumatic, simple as possible, avoid infection. There are some numbers of implant survivors from different references. Some suggest that, Farzad et al. Suggests that the first yield success of implant in diabetic patient is 94%. Mori et al. Suggests that after 5 years, or assume that that success of implant is 89% 5 years, which is very adequate. In a very important systematic review in 2016, dental implant and diabetes mellitus in a systematic review, a very important one, assume that the survival rate of implant in diabetic does not differ from the survival rate in healthy patient within the first 6 years. But in long term, as 20 years or something, a reduced implant survival can be found in diabetic patient. The most important thing in this review, it suggests that the controlled level A1C from 6 to 8% will having a success rate up to 10 years. And this is a very important. From success to 8, A1C will have a success rate of 10 years. And this is a very important. It's comparable to the normal patient. These numbers suggesting that you have to ask your patient about, or you have to suggest and offer your diabetic patient, if he's controlled, if he's taking his medication, is he practicing any kind of exercise, you have to suggest implant, because this number is very promising. The surgical technique itself. Actually, there is no certain guidelines that you have to use the flapless technique or the full thickness flap, but you have to remember this patient cannot deal with infection. So according to the situation, you have to choose if it is a flap technique or open flap technique or a flapless one, according to the situation. It's not related to his diabetic condition. As we said before, the timing is very important of the surgery to avoid any hypoglycemic complication. The timing in relation to the insulin and his meal, this is very important also in planning your surgical timing. There is a conflict in this area about using long or short implants in diabetic patient, but there is no recommendation to use either or neither one of them. While in surface treatment of implant, it's very suggestive that using the sandblasted or the acid etched, having very good prognosis with poor glycemic control. The platform switching technique using an abutment that having a narrow diameter than an implant, also discussed in the lecture with a higher success with diabetic patients. As we said before, using a flaplix technique or a full thickness, there is no difference between them. It's according to the situation you have. You only have to consider the risk of infection and complexity. Using the submerged implant versus non-submerged, the evidence actually submerged seeming to have or perform better than non-submerged implant regarding peri-implant bone loss, according to 2020 protocols or guidelines, and I will submit these references at the end of the lecture. Is there any recommendation of the specific restoration you can use with diabetic patient? No. If your patient having a good glycemic control, you can use a different type of prosthesis with your implant as a single crown, bridges, overdenture. There is no specific recommendation. After surgery, I know that most of us thinking with diabetic patients, should I use a prophylactic antibiotic? And if I'm going to treat him with implant, should I use a prophylactic antibiotic? Also, there is a debate in this area, but a recommendation of prophylactic antibiotic from 7 to 10 years to 10 days could be very beneficial sometimes. But as we know, all antibiotic will not help you as much as your work will do. So you have to do a traumatic surgery. You have to have a specific time for recall, assess your patient with a periapical radiograph to assess a peri-implant bone loss. Using the floss is very important. Using of an antiseptic as chlorhexidine is much more important than using a prophylactic antibiotic. So if your patient is controlled, you do not have to worry about using a prophylactic antibiotic as normal patient. To sum it up, how to assess the patient glycemic control? I said by fasting level, A1C, and finally, we are not treating numbers. So you have to collect more than one number, and you have to know every single information and details about your patient, his medication, his condition. Remember, your diabetic patient is a very important patient in your clinic. So you have to set up a biannual recall for your patient. Any diabetic patient should be seen in your clinic because they're having a very high risk factor for periodontal disease. Remember, if you are going to go for implant or any advanced surgeries, you have to decrease the complexity as you can. We do not want infection. We do not use, sometimes it's an easy example to use a bone graft or a specific flap technique or a ridge splitting. But in diabetic patient, this option may complicate his situation. I cannot end up this webinar without talking about the emerging evidence about the bidirectional relation between diabetes and gum disease or periodontal disease. It has been discussed for years that there is a bidirectional relation between diabetes or the A1C for patient or the glycemic control for the patient and periodontal disease. Periodontal disease is a kind of chronic inflammation in your body. Releasing of inflammatory mediators in your body can affect different organs. So we know that most of diabetic patients will have an active and aggressive periodontal disease, but sometimes we forget that periodontal disease can complicate the glycemic control or can complicate the diabetes itself. So if your patient is diabetic and having an active periodontal disease, remember that debridement, scaling can enhance his glycemic control, as we have a bidirectional relation. Maybe it's not a strong evidence than now, but still suggested at different papers. Finally, these all most of the references I used, Scully, of course, from medically compromised patient, the 6th edition, Little and Flack, and the other recent papers suggesting the using of an implant in diabetic patient. from Springer and other different references. Thank you. And I think I can hear your questions now, and I hope everything clear.
Thank you so much, Dr. Isra, for this informative session. It was a very, very nice presentation, very clear. Thank you so much. Meanwhile, I'll ask your permission to introduce our company to all the participants, and I request all the participants to kindly put their questions in the question and answer box, and we will answer the questions at the end of the session. So this is our organization, DentistChannel.Online, Healthy Smiles, Wealthy Lives. DentistChannel.Online is India's first digital dental media company. We did webinars and courses with more than 400 national and international speakers, many successful world implant expos and workshops. If you're not a Prime member yet, kindly join our family to get free certificate of participation after every event and get exclusive offers and discounts on our on-site and online paid workshops and courses. Prime members will be awarded with 1 CPD CE point for each webinar. So if you're not a Prime member yet, to join our family using the link provided in the chat box and use my code SAR100 to benefit from a discount. So you'll be paying around $10 per year. This is an example of the certificate of participation that you will get after every event. About our upcoming webinars, we have 2 webinars tomorrow, one happening with Dr. Patricia about immediate implant in aesthetic area, and another one with Dr. Mahmoud Ramadan about patient complaints in removable prosthodontics. On May 21, Dr. Mahmoud Salama will be giving a session about easy techniques for shaping and clinical tips before obturation. And on May 22, Dr. Madiha will be giving a session about dental marketing, the ongoing social media trends. I request all the participants to kindly save this number and then send a message on WhatsApp with their name, so they will be added to our broadcast list and they will receive everything about our upcoming dental webinars and courses. Today's webinar is sponsored by NovaMind. NovaMind offers a full spectrum of implants and prosthetic solutions that accommodate any clinical need in modern implantology. We successfully supply highly demanded dental implant types called internal hex, tissue level, bone level, and active conical connection. Our EU production unit and product quality is appreciated worldwide. Dental implants and dental restorative solutions produced maintaining all the standards of EU medical device regulatory. Products are manufactured in Athens, Greece, and distributed worldwide with more than 1 million happy restorations. If you want to know more about NovaMind, kindly check their website. Last but not least, don't forget to follow us on our social media platforms, Facebook, Instagram, and YouTube. So now it's time to move on to the question and answer session. But I don't see any question. It seems that everything was very clear, very well explained. Yeah, thank you so much, Dr. Isra.
Thank you, Dr. Sarah, and thank you for sharing this webinar. Thank you.
I would like to thank you for sharing your valuable knowledge and experience with us. It was a very nice presentation. Thank you so much. I hope we can collaborate more in the future.
Thank you.
Thank you. Have a good night. Have a good night, everyone.